manuality of the S-step protocol. Now, traditionally, you'll see in the textbooks where they're pointing the probe onto the organ, and that used to be okay when the probe head was a nice wide footprint, but now our probe heads are getting smaller and smaller with the microconvex probe. So what we need to do is we need to make sure that we're not causing discomfort onto the patient with a poke and prod session. The way you hold it is like you would a racquetball racket or a tennis racket, with your thumb over the marker for your orientation, so you know where your thumb is. It's always pointing towards the head of the patient, and then the forefinger is up over the top. And so what we're doing is we're using our hand with our fingers and our thumb and our forefinger to move things out of the way to create a more harmonic acoustic window with every organ. So if the colon's in the way, I'm going to use my fingers to move that colon out of the way. If I'm dealing with a deeper structure, I'm going to create sort of a claw with my hand, and I'm going to push on in to where I am going to move artifact out of the way and condense the tissue so I have a more harmonic medium to pass the ultrasound waves into. And that's how you can create a much prettier image even with the lesser machines. And so you can minimize the real estate, is what we call it, by pushing into the body wall. But we're not poking the patient with the probe, which creates obviously discomfort for the patient and may damage the probe. So what we want to do, again, hold it like a tennis racket or a racquetball racket or a ping pong paddle, whatever sport you might play, thumb on the marker, and manuality over the top. Now the three maneuvers that we're dealing with, we are going to fan or tilt. Okay, a tilt would be like this, or fan is when we're going from edge of the organ back to the edge of the organ. 1/1000, 2/1000, 3. So everything's in 3 seconds. Everything's a 3-second maneuver. We want to make sure that the tail of the probe goes straight up and down and not like this or like that, because if you drop the tail of the probe obliquely, your organ is going to be oblique. If you drop the tail of the probe straight up and down, then you're going to fan through the organ where both poles of the kidney, for example, are going to disappear at the same time. Both poles of the adrenal gland are going to come into view at the same time and disappear at the same time. So this keeps you in line with long axis of the organ. The other maneuvers, in addition to a tilt or a fan, is a twist. Okay, so when you twist the probe, you lengthen out the organ that we're looking at. Whether it's an aorta, you're going to twist to lengthen it out. Maybe you twist that far, maybe you twist that far. You have to adapt to the long axis of the organ, not the long axis of the animal. And if you're an adrenal gland and you want to lengthen out the pinna of the left adrenal gland to get both poles, you're going to twist slightly. If you have a longer organ or like a spleen and you want to lengthen it out, you're going to twist much more with a more dramatic maneuver. Okay, so we have a tilt and we have a twist, and now we have a slide. So let's say we're sliding up and down a long organ like the spleen or even a bladder that's really full. So we're going to slide to go up and down the organ, cranial and caudal, fan to go edge to edge, and twist to lengthen. That's all you have to do throughout the abdomen. So if one maneuver isn't working, the other one will. The other term I'll use is called tethering. Now, tethering is fanning from organ to organ. The classic one is the urinary bladder, where you're going to go from edge to edge and tether the urinary bladder. So you want to make sure that you fan through the whole organ and you get both edges of the bladder or the kidney or the adrenal gland or the liver or what have you. So you're going to tether it edge to edge from capsule to capsule. Talking about micro maneuvers, so our normal maneuvers, we're tilting and fanning, we're twisting, we're sliding. Micro maneuvers, when we use that term, we're talking about a tiny twist, a tiny tilt like this, a tiny slide. All right, and that's very important when you're talking about intercostal approaches with small dogs especially. So it doesn't take much to really find that sweet spot of a really nice image by just using the thumb and forefinger and little tiny twists, little tiny tilts, little tiny slides, okay? So you're really not moving much. So when you want to refine an image, those are the micro maneuvers we want to utilize to really pop that image onto the probe, and also pressure. So if you add a little bit more pressure, it's amazing what will happen to your image, and it will really pop for you. Also, a little twist sometimes makes it come in really nice. A little tilt comes in, and use one of those 3 or 4 micro maneuvers to really optimize your image wherever you're at. In this case, intercostal, but it could be in the left adrenal or wherever. So that's what micro maneuvers are. And it's important at this point that you're scanning 1 arm's length distance to the screen, and your shoulder is equal with the shoulder of the patient, because that will keep the probe tail cranially. If you're standing back by the back legs of the patient, you're going to keep dropping the tail of the probe caudally, and you're going to be too oblique. You have to come forward and scan your shoulder to the shoulder of the patient, and that will keep the tail of the probe straight up and down. So now what we're going to do is we're going to demonstrate the S-step protocol of the abdomen, starting with position 1. Position 1A, 4-chamber long axis. We are imaging from underneath here, and this is the cardigo, and see how the chest just drops into the hole here. And this is a border collie, so we're about halfway into the base of the triangle, which is right here. So what we want to do is, here's the sternum where my thumb is. All right, so we're going to be just to the right of the sternum. And what we want to do is we want to start as far cranial as we can. I'm even going to go underneath the cardigo here, and I want to start up towards the axilla and slide caudally until I have a beating heart. And I want to maintain as far dorsally towards the spine. The spine's here, sternum's here, so I want to slide up towards the spine as much as I can to flatten out the heart, because if I come back like this, the heart is tilted. You have to be up towards the spine and find a nice flattened heart, and you have to keep the tail of the probe cranially. The cranially is on the left of the screen here. You have to keep the tail of the probe cranially, because if you drop the tail of the probe, then it becomes a tilted heart, which is great for the mitral valve and mitral Doppler, which we'll talk about in a minute. But we want to start from the axilla area and slide caudally until we have a beating heart, and then you twist to lengthen, and as you twist, you have a nice long left ventricle, okay? If you go towards the sternum, you're going to squeeze that left atrium down, and the heart is going to get tilted. Whereas if you slide dorsally towards the spine, the heart flattens out, and you have a nice 4-chamber. Okay? Keep the tail probe cranially, and keep towards the spine to flatten the heart. So when you have a nice clean 4-chamber, this is position 1. So you just stay here. Once you have your spot, stay right there, and now it's just stomology, so I'm going to push my M mode and get my LVM mode, get a couple of contractions across the screen, freeze and save. Maybe I'll do that a couple of times. And I'll go take the cursor and move it to the right just a little bit and get my EPSS. Get a couple of clean ones there, and I'm keeping my M mode in place. I'm not moving my probe at all, because I'm in a nice spot. Now I'll go back to B mode, and I will freeze and then scroll until the mitral valve closes, and that's my 4-chamber to get my LA max measurement, which I can take now and go from atrial septum to atrial free wall and freeze that. Okay, so I'm still in 4-chamber, and I got 3 of my crucial measurements. Now what I want to do is I want to do my mitral valve Doppler. So the way I do that is, now instead of having a flattened heart, I'm going to tilt caudally, and maybe in this dog I'm going to go caudally a rib space just a little bit, to where I put the mitral valve as far into the right part of the screen as I can, and then I color flow, and my sector is going to be about 1/3 to the left of the mitral valve and 2/3 to the right of the mitral valve. And if my image is not clean, I will go back to B mode, get a cleaner image, and then start my Doppler again. I want to make sure that I see my Doppler jet. In this case, the mitral jet is going right down the middle of the screen, right into the middle of the left atrium. It's a centralized jet and not a peripheral jet. So I have to line up my CW to match the direction of the mitral. Insufficiency in this case. And as I do that, I'm going to be off angle in this view, so I'm going to wait until I get to position 4 and do my mitral Doppler in position 4 because it's a centralized jet. If it were an eccentric jet, which is the case most of the time, then I would have been down in this area here with the color flow and then the spectral Doppler. So that's position 1 and 4-chamber long axis. Now we're going to go to position 1B. The position's the same, so we're going to start cranially and slide caudally until we have a nice 4-chamber. And if I'm tilted, I'm going to slide towards the spine a little bit. And now we're going to go to 5-chamber. That means we're going to let the aorta come in. And the way we do that is we drop the tail of the probe and do a slight twist towards us, just a slight one. And then we get 5-chamber. So we go from 4-chamber, twist away and drop the tail. 5-chamber, bring the tail toward us and twist towards us just slightly. 4-chamber to 5-chamber. 4-chamber to 5-chamber. And if you try to do that when you're towards the sternum, you're going to be offline. And you may get lucky and get a nice June Boone LA to AO ratio, but you're going to be more accurate if you're up towards the spine a little bit. So from here, when we're in 4-chamber, then to 5-chamber, as you can see, 4-chamber to 5-chamber, tiny twist, tiny tilt. If it's a big dog, I'm doing a big twist and a big tilt. If it's a small dog or a cat, it's a minute maneuver. So 4-chamber to 5-chamber. 4-chamber to 5-chamber. I'm going to save us an efficiency clip of that, 4-chamber to 5-chamber. And now I want to make sure that my aortic valve is right in the middle of the screen and my aorta is maximum width that I can make it. So I'm going to move up and down just a little bit towards the spine and back towards the sternum and without leaving the aortic valve. So I'm going to tether that aortic valve. Now I'm going to run my M mode right through the aortic valve and get my LA to AO June Boone. And freeze it, save it, get a couple of those. I'm not moving my probe. M mode. Freeze, save. Okay, so I'm going to go back to B mode now. And here with my aortic valve in the middle, and if you haven't done this a lot, then the easy way to keep the angle of the probe straight, because if you tilt it, you're going to get offline, you have to make sure the aortic valve is in the middle. So I'm going to take my left hand and hold the probe in the position with my right hand, take my left hand and use it to spin the base of the probe so I don't get off axis until I get into the Mercedes-Benz sign or heart base view. And so what ends up happening is a lot of people they'll be in 5-chamber, it's nice and clean and pretty and long axis, and then they'll twist a short axis and they automatically get offline and now you're in the left ventricle. Okay? But you have to stay dorsal here to go from 5-chamber long axis, short axis. So do that at first until you can train yourself to do it with one hand. But if you do it with one hand, it's too easy to drop into the left ventricle. So here we're in a Mercedes-Benz sign, short axis, LA to AO heart base. So I'm going to freeze here when I have a nice, clean Mercedes-Benz sign. Save a few of those. We can measure that out later. And now I'm going to do an efficiency sweep from heart base to fish lips, to mushroom, and back to heart base again. Okay? In this dog, it's an intercostal view. But all I'm doing is moving the probe across a rib. But I'm not pushing with the probe, I'm pushing with the top of my hand. So the dog doesn't feel it. So it's like holding a beer and pushing on up. Okay? So I'm in heart base view, nice Mercedes-Benz, sliding caudally a rib space, through fish lips and into mushroom. And I'm going to play around with my angles a little bit here to make sure that my mushroom view is nice and even between the two papillary muscles. And then I can switch back to long axis. Go to 5-chamber long axis where you have your aortic valve in the middle, and then twist to short axis, and then sweep back through short axis and then back to long axis again. So if I'm in long axis 4-chamber, I can go to 5-chamber, twist to short axis, sweep, heart base to mushroom, back to heart base, and back again. Let's do that one more time. 4-chamber to 5-chamber, twist to short axis, sweep, short axis sweep, back to heart base view, back to long axis, 4-chamber and 5-chamber. That's a beautiful efficiency clip that has a ton of information in it, and you can tell so much about the heart in just that 3-second video clip. So now what we're going to do is we're going to move towards position 2. Now what we're going to do is we're going to move towards position 2, or E on the poster, position 2. So from position 1, 4-chamber long axis, what we're going to do is come caudally a little bit, maybe a rib space in a bigger dog. You're going to bring the tail of the probe caudally now, just like you did for the mitral valve to do mitral Doppler, but now you're going to point towards the right shoulder, and this puts you right on the tricuspid valve. If you push too hard, you're going to push it out of the way. You let that tricuspid valve come into view and play in a couple of spaces between one rib space and the other, and you're going to slide pretty much towards the sternum. As you slide towards the sternum, then that gives you a little bit of a better angle and underneath that lung field. The Cardical will help you keep that lung field out of the way, but you can use the top of your finger here to keep the lung out of the way as well and stay towards the sternum. So as I point towards the right shoulder and raise the tail of the probe, I get the tricuspid valve. And as I drop the tail of the probe, I get the pulmonary artery. And if I want to lengthen the pulmonary artery, it's a twist. Just like any other lengthening of the structure is a twist of the probe. So tail up, tricuspid valve. Find your sweet spot. Tail down, pulmonary artery. Find your sweet spot, twist to lengthen. Okay, so I'm going to play with the tricuspid valve right now. I'm going to get it as clean as I can. And then from here, I'm going to add my color flow, see if there's a regurg jet or not. If there's a regurg jet, then I'm going to put the pulse wave right over the regurg jet and measure that, and that checks for my pulmonary hypertension. I take the color flow off, go to B mode, drop the tail of the probe, get a nice pretty pulmonary artery, and I'm going to move back and forth and fish around, find my little sweet spot, and once I've got it, then I'm going to color flow over the pulmonic valve. Spectral before the valve to check for insufficiency jets. Spectral PW past the valve to check for outflow velocity. And if I want to check for PDA, I'm going to put in a deep pulmonary artery and look for that holosystolic jet. And you want to do an efficiency clip here, because this, especially if you're looking for pulmonic stenosis and PDA, your efficiency clip will really help here on looking at the anatomy of those defects. So if I raise the tail, tricuspid, lower the tail, pulmonary artery, 1, 1000, 2, 1003, maybe I'll change my angle, a rib space, 1, 1000, 2, 1003, 1, 1000, 2, 1003. So I'm just going back and forth from tricuspid to pulmonic valve and pulmonary artery at different angles, especially when you're doing a congenital study. You want to get 2 or 3 angles of that to make sure you cover everything. So that's position 2. So S-step echo position 3 is actually a really quick maneuver, and you use it when you've done an abdominal scan, you find a splenic mass, so you jump up and do a position 3 that's very quick. So point of reference here on this OSSI, here's a subxiphoid area here, so if I slide cranially now about 3-4 intercostal, and I have the sternum right here, I'm going to use the back of my hand here to kind of push against the lung, and then just put the probe right off of the sternum, off the sternum. You're going to fish around a little bit here until you find the right ventricle and right auricle, right atrium and right auricle and tricuspid valve. And so what I'm doing here is I'm pushing down to close down the lung. And if you have lung artifact, just move around a little bit. Don't be afraid to kind of jump around and find that acoustic window that you want, because it's really small, but it's a beautiful shot of the right atrium and right auricle and tricuspid valve. And you can do your tricuspid Doppler from this position as well. So you center the tricuspid valve and put the color flow, especially if you're checking for pulmonary hypertension, for example, put the color flow first and then the PW Doppler on any regurg that may be there. And this dog has a little bit of physiological TR. And you can record that and get up into that right auricle as best you can by just maneuvering around, changing your angles, micro maneuvers, and utilizing the back of your hand to close down that lung a little bit further and create a little bit more of a window, because you really don't need much. You just need a little bit more pressure sometimes and get way up into that right auricle to make sure that you're not dealing with a right auricular mass or a pericardial effusion that may be in an early phase. Okay, in position 3, the micromaneuver is essentially this. You use the back of your hand and the fingers to push up against the lung. And we're just finding that little sweet spot. And don't be afraid to move around and find that little sweet spot. But I'm not pushing the probe down on the patient. I'm using my fingers to push the lung down, and the probe's just along for the ride until I find that right ventricle or right atrium to work from. And once I have that, then I'm going to micromaneuver a little bit further, just a little tilt, little twist. And again, I'm not pushing the probe against the patient, I'm pushing the hand against the patient until I find that little sweet spot where, boom, I've got the right atrium and the right auricle tricuspid valve. And again, before you use the color flow on anything, make sure your B mode is crisp as it can get, because color flow and spectral Doppler are very sensitive to interference. And that's position 3. So position 4 S-step is very easy as well. So if we were here on 3, we're just going to go subxiphoid here. And it's very similar to position 11 on abdomen, but I'm just going to go subxiphoid. My thumb is on the marker, and I'm going to use the top of my hand to push against the abdomen just a little bit and make myself a little window. And I'm going to increase my depth because we're covering a lot of ground here. And I am just going to angle to where the heart is in the middle of the screen. And I'm going to twist the probe just slightly. And again, it's very flat against the linea alba here. It's not like this. If you're like this, the heart's going to go to one side or the other, okay? You need to flatten it against the linea. Use the back of your hand to move the viscera towards the spine and get up underneath the xiphoid and find a beating heart, and that's a start. And then you just twist to lengthen the left ventricular outflow. Color flow. Get a clean B mode first, then a pretty color flow, and then your Doppler. So then you're going to go your spectral Doppler, you get your outflow velocity, post valve, and then you get your insufficiency jet prior to the valve itself. And if this image is giving it to you, so this dog doesn't have any volume overload, but when you have a volume overload case and you want to get the MR, you just change your angle a little bit and twist to where you get the mitral valve in the center of the screen, and then you color flow your mitral valve. And this is especially important when you have a centralized mitral insufficiency jet, to where you can get the maximum velocity by lining up the CW with 15 degrees theta. What we want to do for position 4, again, slide back until you have this, the xiphoid, and use the back of your hand to push up against the viscera and make this little pocket for your probe, and the marker is towards you. And so with this view, we get a nice long aorta. We twist to lengthen the aorta, but we can't bring the tail of the probe like this because the heart will go off the screen. You have to flatten it against the linea alba and in this little pocket right here, and then twist to lengthen to 5 chamber or left ventricular outflow, and nice long aorta. It's very important you have a nice long aorta and clean B mode before you go to your Doppler. And then you can twist to go to 4-chamber, okay? 5-chamber, 4-chamber, 5-chamber, 4-chamber, okay? The last maneuver that we do is to check the liver. So what I do is you want to change your depth again, okay? And I'll switch the orientation marker towards the spine because we're in cardiac orientation, but we're actually imaging the liver. And so I'm just going to do a sweep of the liver here, just like we would in a position 11 abdomen. And what that'll allow me to do is check to see if hepatic vein congestion is there, and I'll look at the vena cava going through the diaphragm, okay? And that way you can check to see if pulmonary hypertension is becoming clinical and turning into right-sided failure or not by just doing this sweep. So it's 1, 1002, 1003, and find the vena cava going through the diaphragm, and you can measure that if you like as well. It should be a 1-to-1 ratio with the aorta. On the S-type protocol, usually when we're doing an echo, the head is towards the machine. They're on the right side down. And we usually do a transdiaphragmatic view to get the aortic outflow so we don't have to flip the animal. But when we're having trouble getting that aortic outflow, what we can do is go back to the traditional approach with left-sided down, head away from the machine. And in cats, you really have to be lined up with the body wall in order to get the aortic outflow accurately. Otherwise, it's going to be offline. And you have to, in order to do proper Doppler, you have to line up the probe and the angle of incidence within 15 degrees theta. So in a dog, you typically stay just caudal in the last rib adjacent to the sternum. But in cats, you have to go really high, about 1/3 of the way up the rib cage, in order to be able to be lined up with the aorta. And when we do that, we find our little niche, we find a beating heart, that's a start, and we just do little tiny twists till that aorta comes in clean. And you can see that as the sound waves come through, they're going to be lined up correctly with the aorta. You have to be high on the chest, about 1/3 of the way up the chest, flat, and pointing towards the eyes of the patient. And when you do that, then the aorta will be lined up correctly. And from that point, you can get a nice clean envelope. And that is position 4. Very quick, very rapid, very effective. Now we've taken you through the complete S-step echocardiogram protocol. You can see how efficiently you can be as you progress from 15 minutes to 12 minutes to 10 minutes to 5 minutes. If you work at it in a focused, progressive fashion, you can develop a very efficient protocol day in and day out, patient to patient, whether you're scanning a cat to a bulldog to a German Shepherd, it doesn't matter. The protocol is all the same. And you can combine these different views and obtain all of the proper images that we need for interpretation, whether you're interpreting in-house or sending it to a remote specialist, as well as combining all of the views that are necessary for congenital studies. So this never replaces, of course, a cardiologist, but it creates a situation where we have image sets that can get us everything that we need to know which direction to take the patient, whether it's cardiac or not, which medications to use, if it's respiratory or not. This protocol will help you do that. We are here to support you in every part of clinical sonography, from machines to training, virtual training, on-site training at our facility here in Andover, New Jersey. So anything you need from us, info@sonopath.com, and we're here for you. Thanks for watching. Hello, I'm Dr. Eric Lindquist, and here we are for S-Step Canine Echo Emergency Protocol. So from this point, you have gone through the S-Step Echo protocol. Maybe you are scanning at 15 or 20 minutes to get the full protocol done. Now we're going to kick it up a notch to do an S-Step Urgent and then an S-Step Emergency. And why do we do this? Well, if we have a respiratory distress patient or a coughing patient, we need to know, is this a cardiogenic pile of drugs that we're going to utilize, or is this a respiratory pile of drugs that we're going to utilize? And we have radiographs that may be nebulous, so we're not sure, is this cardiogenic or not? That's what we're here for. How do we tell if it's respiratory or cardiogenic? It's all about the left atrium. In order for left-sided congestive heart failure to happen, you have to have a big left atrium. Even if you've given Lasix and the patient's clinical with a cough or with respiratory distress, if it's cardiogenic, the left atrium is going to be big. And we're going to measure in 3 different ways during the protocol, and it's very important to compare all 3. The LA max is the most important. If you get one view, get a 4-chamber long axis and an LA max. That will tell you, is it this pile of drugs or is it that pile of drugs that'll settle this patient down clinically. So we don't want to stress the patient. We'll use gabapentin or torbitrol to help calm the patient. We don't want to kill them with a probe by pushing them too hard. So be very, very careful in these patients as far as stressing them with the probe. What you want to do is get your speed up gradually from 20 to 18 to 12 to 10 to 5 minutes and get a full protocol. And you can do it, and we're going to show you how to do it today. It has a triangle in the middle. Larger animals, you scan towards the base of the triangle. Small animals, from cats to chihuahuas, you scan at the top of the triangle. And you scan underneath, you can see, but the animal actually sinks down. S-Step Echo Urgent and Emergency. Remember, it's a twist, it's a tilt, it's a slide. Okay, don't make it any more complicated than that. Here we go. We're going to start with position 1. 4-chamber long axis to clean the brick up. We're going to slide dorsally to flatten the brick, get the twist to get the papillary out. From here, once we have our brick, we're going to go LVM mode. When we start to get the LVM mode, we want a left ventricle that's nice and flat, no papillary. LVM mode, the cursor is perpendicular to the septum and the free wall, no papillary in. Freeze, save, we can go back and measure later. Keep your brick, move the cursor over to the right to get the EPSS. Back to B mode, 4-chamber long axis. Close mitral valve, save a couple of those to work on later. Then twist to 5-chamber, get that LA to AO right in the middle. Transect the aortic valve, get it nice and clean in your M mode, save a couple of videos of that. Now what I'm going to do is I'm going to save video clip of 4-chamber to 5-chamber, 4-chamber to 5-chamber. Then I'm going to twist to short axis, Mercedes-Benz, freeze, save, get a couple of those. If your Mercedes-Benz isn't clean, slide dorsally towards the spine. If your aorta is not clean, slide towards the spine. Save again, get a couple of them, save again. This is just the urgent version, okay? Now I'm going to run through the short axis sweep, Mercedes-Benz to fish lips to mushroom. Get a couple angles of that. Now I'm going to go back to long axis, mitral valve, color flow, CW, if there's an MR, you're going to need CW. Save a couple of those. You can PW if you want, but don't waste your time. Now I'm going to go to position 2. Since I've finished with 1, I'm in 2. Point towards the right shoulder and bring the tail of the probe caudally, pointing towards the right shoulder of the patient. Color flow over the tricuspid valve. You want about 1/3 to the left of the tricuspid valve, 2/3 of the sector to the right of the tricuspid valve. PW. If you have an A-listing jet, go to CW. Get that TR jet, make sure there's no pulmonary hypertension. Now we do a sweep from tricuspid to pulmonary artery, and you're just pointing to the right shoulder, dropping the tail of the probe. If your image goes dark, sweep over and get some more gel, bring it back. We're moving right on through, so we're going tricuspid to pulmonary artery, save a video of that. Color flow over the pulmonary artery, save that. PW prior to the valve, save that. PW after the valve, save that. Then deep pulmonary artery, if you're considering a PDA, put the color flow over that, followed by CW in the deep pulmonary artery. You'll get a whole systolic jet, save that. So we've done position 1, position 2. Now just take a few more sweeps to get a global view. I'm going short axis to long axis, 4-chamber to 5-chamber, taking videos of this to make sure I've gotten all the structures I can go back and look at afterwards. Now I'm going to go over the top to position 3, use the back of my hand, slide up the sternibray and close down that lung and look for that right auricle. This dog has a challenging right auricle. I mean, get right up in there, get up in that auricle as much as you can if you're looking for pulmonary or for hemangiosarc or pericardial effusion. You can do your tricuspid Doppler here if you want. Just work your angle till you got it, then you're done. Don't waste time there. Subxiphoid. Flatten the probe up against the linea alba, so you're right under the xiphoid. Get a nice long aorta, get a couple of video clips, go 4-chamber to 5-chamber. Color flow over the aorta. PW prior to the valve, save it. PW after the valve, save your outflow velocity. If it's A-listing, bring your scale up and bring your baseline up on your LVOT and your RVOT. In your MR and your TR Doppler, the baseline will be in the middle. If it's A-listing, go to CW. The last thing we're going to do is we're going to get a sweep of the liver, and we're going to change our orientation from the marker towards the head to the marker towards the tail. Come underneath the xiphoid, point towards the head of the patient, tail up, tail down. We're just sweeping the liver to look at the hepatic veins and the vena cava as it goes through the diaphragm to see if there's any passive congestion that would indicate right-sided heart failure. If you do get passive congestion and your TR jet is not over 3 meters per second, go back and get a TR jet if the patient is stable and allows you to do so. And now that you have done S-step urgent, we are going to do S-step emergency. Now this is for the critical respiratory distress patient you need to get through as fast as you possibly can. So work up to this, because you never know when that patient's going to come through the door, and you're going to have to get a full image set as fast as possible. If you're having trouble getting images, don't struggle here. Get what you can. Worst case scenario, get a 4 to 5-chamber long axis video clip, or get a long axis to short axis video clip, 2 or 3, put the patient in an oxygen chamber, and go back and look and see, is the left atrium big or not? In the end, that's all that matters. Okay, here we go. Position 1, long axis, 4-chamber. M mode. Save. LVM mode, move over to EPSS, save. B mode, 4-chamber, save. 5-chamber, save. M mode, June Boone, save. Back to 4-chamber, mitral valve, color flow, save. CW, save. Go to short axis, sweep, 1,000, 2, 1,000, 3. If the aorta doesn't come in clean, go a little higher on the chest. Mercedes, fish lips, mushroom. Go to position 2, tricuspid, point towards the right shoulder. Tricuspid to pulmonary artery, save a clip. Color flow
over the tricuspid. If you have a jet there, put the CW or the PW over it, see if there's pulmonary hypertension. Do the same thing down on the pulmonary artery, color flow first. Look for a PI jet prior to the valve, center your baseline, maximize your scale. Look for the PI jet, save. PW after the valve, get your outflow velocity, save. If you're looking for a PDA, color flow in the deep pulmonary artery, PW or CW, save. Move right over to position 3. You should be able to do this in the time frame that it takes for the patient to have a catheter placed. Looking for that pericardial effusion right auricle, get a few angles, 1, 1002, 1003. Go to position 4, flatten the probe, 5-chamber, video clip, 5-chamber to 4-chamber, video clip. Don't be perfect here, just get what you need. Color flow over the aortic valve, mitral valve if it was a centralized MR jet, PW for your outflow velocity, change your scale, raise your baseline. Don't worry about your measurements, you can get those afterwards. Flip the orientation of the probe like we did. We're going to sweep the liver, look for passive congestion. If you have passive congestion, consider your TR jet. Did you get it properly or not, were you lined up or not? Remember, keep your Doppler as clean as you can within 15 degrees theta. Get a clean B mode first, then go to your Doppler, and you're done. That's S-step emergency. Well, Dr. Eric Lindquist again here for S-step echo emergency in cats. We're going to do 2 portions. One's an urgent version, which is fairly fast, and then an emergency version, which is a critical. At this point, you have already been through the S-step echo for cats, and you're roughly at about 15 to 20 minutes of time or less regarding finishing the S-step echo completely. So now we're going to move to a more urgent situation. This is made for patients that are coming in. You need to know right away, is this a respiratory case? Is this a cardiac case? We don't want to stress the cat more than we need to. We take as much as we can that we're comfortable with clinically, but if you can get through the whole S-step echo by practicing over and over and over again and reducing your time that it takes you, then you can get a full echo done in an emergency situation. About the same amount of time that your technician is putting a catheter in. So what you want to do is kind of race the technician and get done before the catheter's placed. That's your target. So here we go. It has a triangle in the middle. Larger animals you scan towards the base of the triangle. Small animals, from cats to chihuahuas, you scan at the top of the triangle. And you scan underneath, you can see, but the animal actually sinks down. All right, let's make this fun. This is not a tense thing. It's a twist, it's a tilt, it's a slide, okay? Tiny maneuvers. Start off the sternum in the cat, give me your position 1. About 4 to 5, 6 centimeters of depth maximum. Start with your brick. Once you have it, M mode. 1, 1002, 1003, save. Move the cursor over to the right. EPSS. Go back to B mode. If you have 5-chamber, put it in the middle. Put the aorta in the middle, LA to AO, June Boone. Get a nice clean aorta. If your aorta's not, if it's pinched off, go a little bit more dorsally, drop the tail of the probe a little bit, and the aortic valve will come in a little bit cleaner. So we're moving a little bit faster now. Go back to your brick, get a nice 4-chamber, twist to lengthen. If you don't get a clean 4-chamber, don't worry about it. Don't try to be perfect in urgent situations. Get a couple of video clips, 4-chamber to 5-chamber, as close as you can get. Go to short axis. So you're going to twist a short axis, get a nice Mercedes-Benz the best you can, and then slide cranially, caudally towards the sternum and up towards the right shoulder. Get a nice video clip of that. And go back to 4-chamber. Only do what's necessary, okay? Because these are urgent things. Get a quick color flow over the mitral valve. If it's not a big deal and you don't see a big left atrium, don't spend a lot of time doing complex Doppler on an urgent case. We just want to get general parameters here to see if this is cardiogenic or not. If you have a little TR jet, maybe you want to grab CW, PW over that. You can get right-sided heart failure. So we want to get a TR jet there, but don't spend a lot of time on it. Go from tricuspid to pulmonary artery, get a couple of video clips. Keep moving to get the sweetest spot you can, the sweetest image that you can. Pulmonary artery. Color flow first. Spectral after. Prior to the valve, ideally, if you have time. If the patient is in a crisis, just keep moving. Yeah, now I'm going to move to position 3, up over the top. I'm going to look for that right auricle. Right off the sternum, push down with your fingers, come off the sternum, find a beating heart, get up into that right auricle. That's all you need. And go right to position 4, increase your depth, subxiphoid, flat on linea alba, twist to lengthen my aorta. I'm going to get a couple of video clips of that first. Color flow over the aorta. PW prior to the valve, look for AI. PW after the valve. Left ventricular outflow velocity. You can do your color flow on your mitral valve here if you want as well. Color flow first and then spectral afterwards. Patient stable, great. If it's not, this isn't important. Get them in a cage, get them comfortable. If you have an aliasing jet, then you go to CW. Last thing you want to do is flip the orientation of the probe. The marker's towards the tail now. And you're going to sweep the liver, and you're going to look for hepatic vein congestion. If you have hepatic vein congestion and you have time and your TR jet wasn't over 3 meters per second, go back to position 2, point to the right shoulder, get your tricuspid valve, get your color flow again, and interrogate that TR jet just a little bit more if you have time. Work on that until you're about 5 minutes or so. So you have an S-step echo done about 5, 6, 7 minutes, and then we're going to work on S-step emergency. This is S-step emergency. We have a critical cat that is in dyspnea, and the technician's putting a catheter in it. Maybe you gave him gabapentin, maybe you gave him a Torbutrol or something just to calm him down. Neither one of those have any appreciative effect on the heart, so they're great drugs to use to calm a patient that's dyspneic, okay? If you have pleural effusion and you need to tap it, you can tap it from here between 10 and 11 intercostal, just caudal to the heart here. So just find a spot and come up right underneath in the cardiac hole, okay? So we're going to start the S-step echo emergency in this dyspneic cat. And here we go. Get a depth of about 4 to 5 centimeters. I'm going to get my clips first. I'm not going to worry about my measurements. I'm going to get my 4 to 5 chamber and go to short axis, get my efficiency clips the best I can. If the patient is in critical state, stop there. Get them in an oxygen chamber. We have what we need. But if you can still keep going, then let's go along with the rest of it. Get our M mode, freeze. EPSS, freeze. LA to AO, freeze. And save each time, or you can save the clips. Go to short axis, stop, freeze. Go back to B mode, 4 chamber if you can get it. And save it. Don't get fancy. Get some color flow if you have time. Any stable. Save the videos, just video. Point to the right shoulder in position 2, get the tricuspid, some color over it. If you've got a blasting TR jet, then PW or CW it for pulmonary hypertension or right-sided failure. Get a clip from tricuspid to pulmonary artery. You don't have to be perfect, you just have to be effective. Pulmonary artery, let's say he's a pulmonic stenosis case, so we put our color flow over it. We put the PW over it. If he is ALISing, we go to CW. We save it. Just keep saving. Patient's stable enough, you keep going, but don't stress him out. Go to short axis, do a short axis clip from Mercedes-Benz to fish lips to mushroom. Don't be perfect, just be effective. Come over the top, get your position 3. Maybe he has a pericardial fusion, maybe there's a mass here. Get up into that right auricle. You can do your tricuspid Doppler here if you have time. If not, don't worry about it. Subxiphoid, increase your depth in position 4, get your aortic outflow, save your video clip. Color flow, maybe there's an LVOT obstruction. PW prior to the valve or after the valve, increase your scale if you need to. Just keep saving. Once you have the position, it's all knobology at that point. Left ventricular outflow velocity, which is important in cats, especially if it's really high and they have dynamic obstruction. Last thing you want to do is flip the orientation of the probe. The marker's towards the tail now, and you're going to sweep the liver. And you're going to look for hepatic vein congestion. If you don't have time and he's dyspneic, then get him back in the cage, get him in some oxygen. But don't kill him with a probe, just get your S-step echo. And you can practice to getting to that speed. It just takes practice, it just takes time, it just takes focus, just like anything else.
Thank you so much for joining us. So as you see, there's limitations for the online webinar. So in the future, we can possibly invite Professor Eric to join us online for live Q&A. And at the same time, we also encourage to stay follow with us, with our local partner, because we having this continue hands-on workshops, training or offline training, so to really experience after the lectures. So also please stay follow with us. Thank you again to join us today. Have a nice evening. Thank you very much. See you next time.
I care about my family, my friends, my career.
I care most about my family, but also I care about my health.
I care about my life and my career.
I care most about my family and friends, and by friends I also mean my animal friends, like my own dogs.
我最在乎的是健康和工作。
We care about our family, about our friends, and of course about our pets. This is our cat Bergamot. He came to our family 2 years ago, and he has grown from the very naughty boy into the very independent and quiet cat with his own personality.
Yeah, that's true. When I'm practicing piano, he usually coming to me, sitting nearby on the bench. So, yeah, he support me and sometimes we're playing together. Well, when we have bad mood, he always can come and give us comfort and fix all troubles. So He's the best part of our family.
That's true.
I work all my life with horses. For me, horses are my friends. I work side by side with them all day. When I was 15 years old, I rode a horse for the first time, and I was fascinated by its speed and the sense of liberty. So I decided to pursue a career with horses. I studied biology, horse biomechanics, and sports science, and now I teach and coach people how to ride the horse. Unlike other animals, horses are very intelligent, sensitive, and talented, and have very strong personality. Once I was riding in the woods, and I came head-to-head with a wild boar. My horse and the wild boar did not want to have anything to do with each other. I wanted to chase the boar, but my horse did not want to listen to me.
It all began when I went to Africa 8 years ago, and that time I met a small elephant who has just been born. I remember I looked into her eyes and I could see myself. At that very moment I knew I should stay in Africa and do my best to take care of them. Men and animals are similar to each other. We all laugh, fight and love. And of course we all may get sick, may be vulnerable, may need help.
The most common difficulties, I would say, are with diagnosis. It's hard to know what an animal is feeling, but if you have the right equipment, you can find solutions for that.
作为一名兽用超声系统研究工程师，我认为兽用设备和人用设备至少有2个方面的区别，一个是操作层面的，动物检查的操作流程跟人用检查是有不同的；另一个是图像层面的，动物类型多，体型差异大，它们对图像的要求跟人用是有明显的区别的。我们一直与国内外的兽医临床保持着密切的联系，收集用户反馈，做了大量的调研，通过大量动物样本的反复验证，我们推出了符合兽医使用需求的简单易用、智能精准的兽用产品和整体解决方案。
Human care and animal care are very different. For this, in our day-by-day, we need very good training and very good products and instruments.
So now we are 16 years further, and it's amazing to see how this company exploded and is now becoming a big player.
We share this planet with animals, and we have to respect and protect them and their habitats, not just for the sake of the animals, but also for our own future.
作为一名兽用产品研发工程师，我们有责任和义务通过科技让动物获得更好的治疗和关怀。
I care about them because they bring me joy every day.
Humans and animals brought the beautiful power of life to this world.
Animals and humans are equal.
Me and animals are best friends.
Cuidado de animales, lo hacemos.
Prendersi cura degli animali, noi li facciamo.
Dierenzorg, daar gaan we voor.
关爱动物，我们一起。
Animal care, we do.
Animal care, we do.
Animal care, we do.